Hello everyone. Today's topic is muscle energy technique. In short, it is MET. Right? MET is a technique that was developed in year 1948 by Dr. Fred L. Michel, and it is a form of manual therapy widely used in osteopathy that uses a muscle's own energy in form of gentle isometric contractions to relax muscles via autogenic or reciprocal inhibition and lengthen the muscles. So basically, it's a manual therapy technique, right? So muscle energy technique is a class of soft tissue osteopathic manipulation methods that incorporate precisely directed and controlled patient initiated isometric and isotonic contractions designed to improve musculoskeletal functions and reduce pain. So basically, muscle energy technique is used to lengthen the muscle, to improve musculoskeletal function and pain reduction. Clear? So MET is based on the concepts of MET is based on the concepts of autogenic inhibition and reciprocal inhibition. So if a submaximal contraction of the muscle is followed by a stretching of the same muscle, it is known as autogenic inhibition. And if a submaximal contraction of a muscle is followed by a stretching of the opposite muscle, that is known as reciprocal inhibition muscle energy technique. So there are two techniques. One is autogenic inhibition technique, and second one is reciprocal inhibition technique. Right? What happens in autogenic technique? There we use submaximal contraction of a muscle that is followed by a stretching of the same muscle. Right? So this is autogenic inhibition muscle energy technique. Clear? Second one is reciprocal inhibition muscle energy technique. In this, a submaximal contraction of a muscle is followed by a stretching of the opposite group of muscle. Clear? So that is known as reciprocal inhibition muscle energy technique. So one is autogenic and second one is reciprocal inhibition muscle energy technique. So this is the main difference in between these two techniques. Clear? Next point is Levinson has observed that to prevent musculoskeletal injury and dysfunction, the individual needs to avoid undue mechanical stress while at the same time improving flexibility and stability in order to acquire greater tolerance to strain Deconditioning through inactivity provokes dysfunction just as efficiently as does excessive, repetitive, inappropriate biomechanical stress. Right? So these excessive, repetitive, inappropriate stresses causes injury in the muscle, joints, and ligaments. So scientist Levinson described muscle energy technique as muscular relaxation technique. And the scientist T.J. Ruddy in year 1961 developed a treatment method involving patient induced rapid pulsating contractions against resistance, which he termed rapid resistive duction. So Rudy's method called as for a series of rapid low amplitude muscle contractions against resistance, usually at a rate of 20 pulsations in 10 seconds. So this approach is known as pulsed muscle energy technique, or in short, pulsed MET, rather than tongue twisting Rudy's rapid resistive duction technique. Right. Next point is the muscle spindle is located within the muscle belly and stretches along with the muscle itself. When this occurs, the muscle spindle is activated and causes a reflexive contraction in the agonist muscle, and it is known as stretch reflex, and relaxation in the antagonist muscle. So this process is known as reciprocal inhibition. Right? So there are a few basic elements in muscle energy technique. Like first one is patient active muscle contraction. This is a very important point. Patient participates actively during the session. Second point is controlled joint position. Next one is muscle contraction in a specific direction. Next one is operator applied distinct counter force. And last one is controlled contraction and intensity of the muscle. Clear? So these are the basic elements of muscle energy techniques. It means you have to focus on the muscle contraction, how you are going to apply force on the muscle, controlled joint position, muscle contraction in a specific direction, and controlled contraction of the muscle. Right? So all these are the important points. Now we discuss types of muscle energy technique. Basically, there are two types. One is autogenic inhibition muscle energy technique, right? And second one is reciprocal inhibition muscle energy technique. So one is autogenic inhibition muscle energy technique, and second one is reciprocal inhibition muscle energy technique. Clear? Now we discuss first autogenic inhibition muscle energy technique. So in this we have two categories. One is post isometric relaxation, that is known as PIR. post isometric relaxation. Clear? And second one is post facilitation stretching. PFS, post facilitation stretching. Right? So PIR and PFS both are the part of autogenic inhibition. Now we discuss post isometric relaxation. So it is a technique developed by a scientist Carol Levitt. It is the effect of decrease in muscle tone in a single group of muscle after a brief period of submaximal isometric contraction of the same muscle. So it works on the concept of autogenic inhibition. So PIR we can use in hypertonic muscles. So hypertonic muscle is taken to length just short of pain or to the point where resistance to the movement is just noticed. Right? Next thing is a submaximal force or contraction that should be 10% to 20% of the hypertonic muscle is performed away from the barrier for between 5 to 10 seconds. And the therapist applies resistance in the opposite direction. The repetition may be up to 5 to 6 times. And the patient should inhale during this effort. Right? Means contraction time of the muscle will be around 5 to 6 seconds. Maximum up to 10 seconds. Clear? And the repetition will be 3 to 5 times. And these contractions may be isometric or isotonic. So after the isometric contraction, the patient is asked to relax and exhale while doing so. So following this, a gentle stretch is applied to take up the slack till the new barrier. So starting from the new barrier, the procedure is repeated 2 or 3 times. Right? The barrier means there is a restriction in movement. The range of movement of the joint is restricted at a particular range. It means there is a barrier. So barrier may be anatomical barrier, it may be physiological barrier, it may be restrictive barrier, it may be elastic barrier. Right? So by MET, you can increase the range, you can lengthen the muscle. Right? You can achieve the new barrier by increasing the range. Clear? So this is post isometric relaxation technique, that is PIR. Right? Next is post facilitation stretch, that is PFS. It is also a part of autogenic inhibition. Post facilitation stretch. So in this, it is a technique developed by a scientist Janda, Janda, Janda. So this technique is more aggressive than PIR, but is also based on the concept of autogenic inhibition. So PIR and PFS both are the part of autogenic inhibition, right? Isometric contractions will be followed by the stretching of the particular muscle, right? So PFS is a technique developed by the scientist Janda, and this technique is more aggressive and based on the same autogenic inhibition concept. So PFS technique is performed as follows. We should consider a few points. Like first one is the hypertonic and shortened muscle is placed between a fully stressed and a fully relaxed state, right? The shortened muscle should be placed between a fully stressed and fully relaxed state. दोनों states के बीच में आपका ये positioning होना चाहिए, right? The next point is the patient is asked to contract the agonist muscle using a maximum degree of effort for 5 to 10 seconds while the therapist resists the patient force. Means asks the patient to contract the trimover muscle, that is agonist muscle, the main muscle, right? So ask the patient to contract the particular muscle for 5 to 10 seconds, right? While the therapist resists the patient's force. We apply a force, resistive force, clear? And the patient is then asked to relax and release the effort, whereas the therapist applies a rapid stretch to a new barrier and is held for 10 seconds. Means you have to stretch a particular muscle to gain a new barrier, right? So hold there for 10 seconds. The patient releases approximately 20 seconds and the procedure is repeated between 3 to 5 times, right? So repetition may be up to 5 times. Clear? So important thing is starting position of the muscle that should be in between fully stressed and fully relaxed condition, right? Ask the patient to contract the muscles for maximum up to 10 seconds, right? And the therapist will apply the resistive force. Then ask the patient to relax the muscle and you can stretch the particular muscle up to a new barrier, right? So that you can gain a little bit more range of the joint. So instead of starting from a new barrier, the muscle is placed between a fully stressed and a fully relaxed state before every repetition. This is the important point for PFS, post facilitation stretch. In every repetition, we have to start from the mid range, means in between a fully stressed and a fully relaxed state, right? Means from a new barrier we should not start. Again we have to start from the same point, right? So this is PFS, post facilitation stretching. Clear? Next type is, second type is reciprocal inhibition muscle energy technique. In short, it is known as RI, reciprocal inhibition MET. So reciprocal inhibition technique is different from the above two technique, and that is involves a contraction of one muscle followed by a stretching of opposite group of muscle. This is the difference, right? So because contrary to PIR and PFS, reciprocal inhibition muscle energy technique, as the name implies, is based on the concept of reciprocal inhibition, right? So in this, we should consider a few points. Like first one is the affected muscle is placed in a mid-range position. First point, the patient pushes towards restriction or barrier, whereas the therapist completely resists this effort or allows a movement towards it, right? And this is followed by relaxation of the patient along with exhalation, and the therapist applies a passive stretch to a new barrier, and the procedure is repeated again in between 3 to 5 times. So this is reciprocal inhibition. In this, isometric contraction will occur, and that will be followed by the stretching of opposite group of muscle. That's why it is reciprocal inhibition, muscle energy technique. So these are the two types of muscle energy technique. One is autogenic inhibition, muscle energy technique, and second one is reciprocal inhibition, muscle energy technique. Clear? So basically in muscle energy technique, we use different types of contractions. Clear? Like first one is isometric contraction, and second one is isometric contraction, and second one is isotonic contraction. One is isolytic contraction, and the other is concentric and eccentric contraction. So we all know about isometric contractions, isotonic contractions, concentric and eccentric contractions. We all know, right? So these contractions we use in MET to lengthen the muscle, to reduce pain, right? So first we discuss isometric contraction. During isometric contraction, distance between origin and the insertion of the muscle is maintained at a constant length. Means muscle length will be constant in isometric contraction. A fixed tension develops in a muscle as the patient contracts muscles against an equal counter force applied by the operator. Operator means therapist. And preventing shortening of the muscle from origin to insertion. So this is isometric contraction. Next one is isotonic contraction, in which the operator's force is less than the patient's force, right? So when we ask the patient to contract his muscle, right? So this is the patient's force, and the therapist resists this movement that is known as the operator's force. So when the operator's force is less than patient's force, that produces isotonic contraction. Means the patient is able to do the movement, right, along with the resistive force. So this one is known as isolectric contraction. In isolectric contractions, it is a non-physiological event. Patient attempts concentric contraction, but an equal force is applied by the operator in opposite direction. In isolectric contraction, operator force is more than the patient's force and useful in cases with the marked degree of fibrolytic changes. So these are the different types of contractions we use in muscle energy technique. One is isometric contraction, second one is isotonic contraction, and third one is isolectric contractions. Right? The main difference in between isotonic and isolectric is in isotonic, the operator's force is less than patient's force. Right? So that the patient can perform the movement. And in isolectric contraction, there is a vice versa. The operator's force is more than the patient's force. That's why it is isolectric contraction. So contractions we use in the muscles during this muscle energy technique application. Right? So these are the basics of muscle energy technique. Clear? Now we discuss indications of MET, where we should use muscle energy technique. In case of shortened, contractured, or spastic muscle, we can use MET to lengthen the muscle. Right? The next point is I strengthen a physiologically weakened muscle. We can use muscle energy technique. Right? If the some muscle is weak, then again we can use MET to strengthen a muscle. If the patient is having pain, acute pain or chronic pain, in that condition we can also use muscle energy technique. To stretch the tight fascia, we can use muscle energy technique to regain normal range. In case of localized edema, for reduction of localized edema, we can also use muscle energy technique. To improve musculoskeletal function, we can use muscle energy technique. Right? Next condition is in case of restricted joint, to mobilize an articulation, we can use muscle energy technique. To improve local circulation, we can use it. So these are the indications of muscle energy technique. Normally we use it for the hypertonic muscles, shortened muscles, contractured muscles, or we can say in case of spastic muscle, we use muscle energy technique. Right? So there are a few elements of muscle energy procedures So we should consider it. Like first one is the patient's active muscle contraction. Means patient should actively participate during the session. Next one is the controlled joint position. Next is controlled contraction intensity, muscle contraction in a specific direction, and the operator applied distinct counter force. Right? Now we should consider the guidelines for muscle energy techniques. There are a few guidelines we should follow during the application of MET. Like first is 3 to 5 repetitions for 7 to 10 seconds each. That is enough, right? So the repetition should not more than the 5, 6 or 7 maximum. And 20 to 50% of the muscle strength should be used. That's why we say it is a submaximal contraction. Right? So 20 to 50% of the muscle strength should be used in MET, muscle energy technique. And the isometric contraction should not be too hard, right? After sustained but light contraction, a momentary pause should occur for 20 to 25 seconds. There should be a pause for 20 to 25 seconds. And the isometric contractions requires a forceful contractions. Right? So these are the basic guidelines for MET. So today we will discuss about muscles also. Upper limb muscles, lower limb muscles, their origin, insertion, action, and the nerve supply. Right? So first we discuss muscles of the upper limb. Their origin, insertion, nerve supply, and action. Like serratus anterior. First we discuss serratus anterior. What is the role of serratus anterior? Anyone? Maria?
This is also
Function of serratus anterior?
punching movement, punch, punching.
Anyone? Gyan? Vikas?
Yes, sir. Yes, sir. Yes, sir.
To help in abduction, sir.
Pardon?
No.
Function of serratus anterior?
सर पंचिंग मूवमेंट कराता है इसको बॉक्सिंग मसल भी कहते हैं
That is protraction of scapula.
Yes, sir.
Right? Protraction of scapula. This punching action. This is done by the serratus anterior. So protraction of scapula is the main function of this serratus anterior. Right? And this muscle is supplied by the which nerve?
Right.
Serratus anterior. That is supplied by the long thoracic nerve. Right? Long thoracic nerve. If this muscle is weakened, what happens? A condition that is known as bending of scapula. We all know winging of scapula.
Yes, sir.
Yes.
That is due to weakness of serratus anterior, right? So this particular muscle, serratus anterior, is supplied by long thoracic nerve. Clear? And the
Yes, sir.
origin of this muscle is from superior border of anterolateral surface of upper eight ribs, right? So it originates from the upper eight ribs. Clear?
Okay, sir.
And the insertion is on the medial scapular border, right? On the ventral surface, you can get on the medial side, medial scapular border. That is the insertion point for serratus anterior, right? Another muscle is trapezius. We can categorize trapezius in three sections. One is upper trapezius, one is middle trapezius, one is lower trapezius, right? So first we discuss upper fibers of trapezius. So function of upper trapezius is it elevates the scapula, scapula elevation, right? If we raise our shoulder up, right, like this, so it is done by the trapezius upper fibers, raising the scapula. That is the function of upper fibers of trapezius, right? Origin is from nuchal line. There is a nuchal line on the back side of the skull. The superior nuchal line is the origin point, and it inserts lateral one third of the clavicle, lateral one third of the clavicle here, right? And the acromion process of the scapula, acromion process of the scapula, right? And this particular muscle fibers are supplied by the accessory nerve, right? Next one is middle fibers of trapezius. It originates from T1 to T12 spine, right? And
Yes, sir.
inserts the superior margin of scapular spine, right? So origin point is from T1 to T12, and that it inserts on the scapular spine, on the back side. Function is it retracts the scapula. Retraction. Retraction is like this, shoulder retraction, right? So this is the function performed by the middle fibers of trapezius, and the nerve supply is same. That is accessory nerve. Basically, accessory nerve supplies all the fibers of trapezius, upper fibers, middle fibers, and lower fibers, right? So origin point is from T1 to T12, spine, right? Inserts at the scapular spine and innervated by the accessory nerve. So this is for middle fibers of trapezius, right? Now we discuss lower fibers of trapezius. The origin point of lower fibers of trapezius is T6 to T12 spines, right? And the insertion point is at the apex of scapular spine. Clear? What is the function of lower fibers of trapezius? It rotates the scapula, right? rotates the scapula laterally, and thus helps in overhead abduction of the arm. Right? So overhead abduction of the arm is done by the lower fibers of trapezius, and it is innervated by the accessory nerve. Clear?
Okay.
So these are the fibers of trapezius, right? Upper fibers of trapezius. It helps in shoulder elevation or scapular elevation, right? Like this. Middle fibers of trapezius. This one retraction, right? And the lower fibers of trapezius. It rotates the scapula laterally, right? So upper fibers of trapezius, middle fibers of trapezius, and lower fibers of trapezius. Clear? Next one is rhomboidus major. Now we discuss rhomboidus major. The origin point is T2 to T5 vertebral spines, right? And the insertion point is on the medial border of the scapula below the spine, on the medial side, right? So medial border of the scapula on the dorsal surface, you can get rhomboidus major. Medial border means towards vertebral column, right? The action is retraction and medial rotation of the scapula. Retraction, same retraction, right? And it is supplied by the dorsal scapular nerve. So origin, insertion, nerve supply, and action. We have to learn. Next one is rhomboidus minor. The origin point is the lower part of ligamentum nuchae, right? And C7 to T1 vertebral spine or rhomboidus minor. The function is same, retraction and elevation of scapula is a function of rhomboidus minor, supplied by the dorsal scapular nerve, right? This is rhomboidus minor. The origin point is from C7 to T1 vertebral spine, inserts at the medial border of the scapula, just above the rhomboidus major, right? Retraction and the elevation of scapula is the main function, and supplied by the dorsal scapular nerve, rhomboidus minor, right? So rhomboidus minor, rhomboidus major, these two muscles are found on the dorsal surface of the scapula on the medial side, medial border of the scapula, right? Now we discuss deltoid. We all know this shoulder contour is formed by the deltoid anterior fiber, middle fibers, and posterior fibers, right? So deltoid anterior fibers, first we discuss. Origin point is the anterior border of lateral one third of clavicle. This one, lateral one third of clavicle is the origin point, and the deltoid tubulosity of humerus. See this? Deltoid tubulosity, V-shaped structure. Deltoid tubulosity of humerus is the insertion point for the deltoid anterior fibers, right? and this is innervated by the axillary nerve. Axilla, right? So you can remember it's supplied by the axillary nerve. Clear? The function is flexion, this one, flexion, and the medial rotation of the shoulder. Medial rotation, this one, inside, medial rotation, right? So deltoid anterior fibers are supplied by the axillary nerve. Clear? Then middle fibers of deltoid. These are the middle fibers of deltoid on the medial side. So origin point is the lateral border of acromion process of scapula, right? And the insertion is the deltoid tubulosity of humerus here. Deltoid tubulosity is the insertion point for deltoid middle fibers. Action is again abduction of the shoulder and supplied by the axillary nerve, right? So this is for middle fibers of trapezius. Middle fibers of deltoid. Function is abduction. This is the function, right? So abduction is done by the middle fibers of deltoid. Now we discuss posterior fibers. This one, posterior fibers. The origin point is the lower lip of the crest of spine of scapula. And the insertion point is the same on the deltoid tubulosity of the humerus. So this is the insertion point of all the types of deltoid muscle fibers. Anterior, middle fibers, posterior fibers. They insert at the deltoid tubulosity of humerus. And the function is extension and lateral rotation of the shoulder. And this muscle is supplied by the axillary nerve. Means all the fibers of deltoid are supplied by the axillary nerve. Anterior fibers, middle fibers, and posterior fibers. Right? Now we discuss latissimus dorsi. So origin point is outer lip of iliac crest from T7 to T12 spines, inferior angle of scapula and lower forelips. That is the origin point. It inserts at the floor of intertubercular sulcus of the humerus here, right? Action is the extension, abduction, and internal rotation supplied by the thoracodorsal nerve, right? So there are so many muscles: pectoralis major, subscapularis, infraspinatus, triceps, anconeus, right? Biceps brachii, brachialis, brachioidalis, forearm muscles, extensor group of muscles, flexor group of muscles, lumbrical, centroceai, right? So you have to learn all these muscles functions, innervation, origin points, and insertion point, right? In this we can discuss biceps brachii. This is the most important muscle in upper limb. So we can categorize biceps brachii in two sections. One is short head of biceps and one is long head of biceps. The origin point of short head of biceps, that is thoracoid process of the scapula, right? And for long head of biceps, that is supraglenoid tubercle of scapula. The insertion point is the radial tuberosity, right? It inserts at the radial tuberosity. The action is elbow flexion in supination position, and it is supplied by the musculocutaneous nerve, right? And the brachialis is the another muscle. Brachialis origin point is the distal half of anterior surface of humerus, right? And the insertion point is the conoid process of ulna and the ulnar tuberosity. And the action is the elbow flexion with the forearm pronated, right? Elbow flexion with forearm pronated, this one. So this is the function of brachialis. Now brachioradialis, the origin point is the lateral supracondylar ridge of humerus, and the insertion point is a distal end of lateral surface of radius, right? Action is again elbow flexion, but in the neutral position, means mid position, like this. This is the movement done by the brachioradialis. So you have to learn the muscles, functions, origin, insertion, and nerve supply of the upper limb, trunk muscles, and the lower limbs. Right? We can discuss here a few lower limb muscles. In lower limb, we have hip flexors, hip extensors, hip abductors, hip adductors, internal rotators, external rotators, quadriceps, hamstring muscles, dorsiflexors of ankle, plantar flexors, right? So here we can discuss few muscles like hip flexors. Hip flexors are the iliacus and psoas major. These are the prime movers, right? And the sartorius and TFL are the accessory muscles. They helps in hip flexion. That's why they are accessory muscle. So now we discuss psoas major. Origin point is the transverse process of all the lumbar vertebra from the ventral surfaces, and insertion point is the lesser trochanter of the femur. And the nerve supply is the lumbar plexus. The function is same, hip flexion, right? Next muscle is iliacus. Origin is iliac fossa. Iliac fossa is found in the hip bone, iliac fossa. Insertion point is the line below the lesser trochanter. Nerve supply by the femoral nerve, right? And the action is flexion of the hip joint. So these are the hip flexors, right? Next is sartorius. The origin point is anterior superior iliac spine, ASIS. That is the origin point for sartorius. And the insertion is the medial surface of shaft of tibia on upper part, right? Sartorius is a talus muscle, the strongest muscle, right? And supplied by the femoral nerve. Function is flexion, abduction of the hip, and the lateral rotation of the hip joint. Flexion, abduction, and lateral rotation. Right? So this is the function of sartorius. And it is supplied by the femoral nerve. Right? It's an important muscle, sartorius. When it becomes tightened, hypertonic, or spasmodic, causes seizing gait. Right? Now we discuss hip extensors. Hip extensors are gluteus maximus, and the supporting muscles are hamstring muscles. So gluteus maximus originates from posterior gluteal line from the gluteal surface, lower part of the sacrum from the dorsal surface, and side of the coccyx. Right? It inserts on the gluteal tubulosity of the femur and into the iliotibial tract of the fascia lata, gluteus maximus, and supplied by the inferior gluteal nerve. Action is extension of the hip joint and lateral rotation of the hip joint. Right? Now we discuss hip abductors, gluteus medius, minimus, TFL. All these are the hip abductors supplied by the superior gluteal nerve. The originates from in between anterior and inferior gluteal lines of the lateral surface of ilium. Right? Ilium is the part of hip bone. So it originates from in between anterior and inferior gluteal line of the lateral surface of the ilium, and the insertion point is the lateral surface of the greater trochanter. Right? And it is supplied by the superior gluteal nerve. Clear? Function is abduction and the medial rotation of the hip joint. Hip abductors. Clear? Now the important muscle is hip adductors. Adductor longus, adductor brevis, adductor magnus are the components of adductor group. Pectineus, gracilis. It originates from superior ramus of pubis and inserts pectineal line of the femur from lesser trochanter to linea aspera, and it is supplied by the obturator nerve and femoral nerve. Right? Next is TFL. TFL we all know. TFL, the function of TFL is the flexion, medial rotation, and abduction, supplied by the superior gluteal nerve. And the origin point is the anterior 1/4 of the iliac crest from the external lip, and insertion point is the iliotibial tract on the lateral condyle of tibia. Right? The superior gluteal nerve supplies to TFL. Superior gluteal nerve also supplies to gluteus minimus and medius. Right? Next is hamstring muscle. Hamstring is a knee flexor. There are three components: semitendinosus, semimenosus, and biceps femoris. Semitendinosus and semimenosus are the components of medial hamstrings, and the biceps femoris is the part of lateral hamstring. It is found on the lateral side of the hamstring muscle. Biceps femoris, right? And semitendinosus and semimembranosus, these are found on the medial side of the hamstring, right? So semitendinosus origin point is inferior medial impression on the upper part of ischial tuberosity. Upper part of the ischial tuberosity. From there it originates. Insertion point is the medial surface of the shaft of tibia, upper part, right? And supplied by the sciatic nerve. Then the other group, that is semimembranosus, originates from the superior lateral impression on the upper part of the ischial tuberosity, inserts the posterior surface of the medial condyle of the tibia into the groove and supplied by the same sciatic nerve, and function is flexion and medial rotation of the knee joint, right? So these are the components of medial hamstrings. Now we discuss biceps femoris, that is a part of lateral hamstring. There are two heads, one is long head, one is short head. So long headed originates from inferior medial impression on the upper part of the ischial tuberosity again, along with the semitendinosus, right? And the short head, lateral lip of linea aspera, from the lateral supracondylar line on the upper two-third and from the lateral intermuscular septum. From there it originates, right? And inserts at the head of fibula on the lateral side, right? Head of fibula. Supplied by the sciatic nerve. Long head is supplied by the tibial part of the sciatic nerve, and the short head supplied by the common peroneal part of the sciatic nerve. Basically, sciatic nerve divides in two branches around the knee joint, around the fibula. One is tibial nerve, and the other part is common peroneal nerve, right? So action of the lateral hamstring or biceps femoris is flexion and lateral rotation of the knee. Clear? So this is the important muscle, hamstring muscle. Now we discuss quadriceps. Right? Quadriceps, there are four components: vastus lateralis, vastus medialis, and vastus intermedialis, along with rectus femoris. There are three vasti and one rectus femoris. Right? So these are knee extensors, quadriceps, and these are supplied by the femoral nerve. Action is extension of the knee joint, and rectus femoris also helps in hip flexion. Right? So origin point of rectus femoris is the straight head from the anterior inferior iliac spine and the reflected head from the groove above the margin of the acetabulum. And the vastus lateralis originates from upper part of intertrochanteric line of femur and lateral lip of linea aspera. Vastus medialis originates from medial lip of linea aspera and lower part of the intertrochanteric line. Vastus intermedialis anterior and lateral surfaces of the shaft of femur, and inserts at the patella and to the tibial tuberosity to the patellar ligament. Right. The function of the quadriceps is knee extension. This is the most important muscle in the lower limb, quadriceps. Next one is ankle joint. In this we have gastrocnemius, soleus, right? Gastrocnemius, soleus helps in plantar flexion, and the tibialis anterior, it helps in dorsiflexion, right? With inversion of foot, tibialis anterior. You can palpate on the anterior side of the ankle joint during the movement. Dorsiflexion along with inversion, tibialis anterior, and the tibialis posterior, it helps in plantar flexion of the ankle and inversion of the foot. So plantar flexion along with inversion, that is performed by the tibialis posterior, right? The extensor group muscles, extensor hallucis longus and brevis, then everters, peroneal group, peroneus tertius, peroneus longus, brevis, right? So you have to learn the origin point, insertion point, innervation, and the functions of all the muscles. In next class, we will discuss how we can apply muscle energy technique on the different muscles, right? So read all these muscles, their functions, the basics of MET, guidelines for MET, right? Then if you want to ask anything, you can ask. Maria, Gyan, Vikas, Prati,
Yes, sir.
right? So
No any questions, sir.